Okay, that's good. Welcome. Good afternoon, or whatever time it is in your time zone. Welcome to Preventive Medicine Grand Rounds for July 6, 2022. My name is Antonio Neri from the Division of Scientific Education and Professional Development at the Centers for Disease Control and Prevention. The Preventive Medicine Grand Rounds is sponsored by the CDC, Preventive Medicine Residency and Fellowship, as well as the Health Resources and Services Administration, Bureau of Health Workforce. The CDC PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders for physicians, veterinarians, and nurses who have completed the Epidemic Intelligence Service Program or have equivalent public health experience. Wanted to note that our application for PMRF is now open for the 2023 class. I'll put a link in the chat momentarily for you to click on. You can see that we use Zoom for audio and presentation, but in a question and answer box to pose questions. Note you can pose questions at any moment during the lecture, and the speakers may or may not work on answering them during the lecture, but we'll try to get to them to the end at the least. Note your name may be associated with the question you posed. Others won't see it, but if you do not want your name to be associated with the question to the host or the speakers, please check the Submit Anonymously box. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDC PMRF. Again, all caps CDC PMRF. If you have any questions, please contact the program at prevmed@cdc.gov. You can see also in the chat we have a closed captioning service, so please use that link if you need it. Please remember the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Before we get started, I wanted to take our usual moment of silence for our colleagues, friends, and families who've dedicated their time, energy, and sometimes lives in fighting the COVID-19 pandemic. Okay. Today's Grand Rounds will be a special one led by a graduate of our mid-career track in the residency, and we're now calling it, by Didi Ebert. She will talk about social determinants of health. And one of the things that she and I were discussing earlier on, and we've discussed throughout this last year, which she was a learner in our class, was I think that the world is starting to better recognize social determinants of health and the issues therein. But there's not as much work on evidence-based interventions. And I'm so appreciative for Didi to be here and having had the time with her for the last year, but also for her work on the social determinants of health and doing something about it. With that, I'll leave it to Didi. Thank you so much for taking time, Didi. The floor is yours.
Thank you. And again, welcome and thanks for joining us today. My name is Didi Ebert, and I, like Tony said, I am a recent graduate of the CDC Population Health Training in Place program, and I completed my work while working at the University of North Texas Health Science Center at Fort Worth at the Texas College of Osteopathic Medicine and HSC Health. And like the views in this presentation don't represent the CDC, they don't necessarily represent the viewpoint of this organization, but my own viewpoints and experience. I will be discussing the topic entitled Addressing Social Determinants of Health in Clinical Care, and particularly learner-integrated approaches to align primary care and public health. The objectives for today's presentation: audience members should be able to describe social determinants of health in their presentation in clinical care, describe the importance of social determinants of health in driving health outcomes and disparities, and recognize strategies to address social determinants of health, including those to align primary care and public health. I know in this group today, there may be many different professional backgrounds and career journeys. So I wanted to first begin by sharing with you a little bit about my own journey so you can have a little bit of perspective. I began my medical career at Texas College of Osteopathic Medicine, and I chose there because I liked the holistic philosophy of osteopathy and that it seemed to align well with public health. I knew I wanted to go into rural primary care, and so I entered a dual degree track to get a DO and PH. And while there, I had the opportunity to participate in an NIH-funded year with additional study of osteopathic manipulative medicine and was able to complete a master's in clinical education and research at the time. I moved on to complete family medicine residency at an FQHC, a community-based program in Waco, Texas. And there, a lot of the graduates move on to do rural medicine and international medicine. So skill sets in community-oriented primary care were emphasized in the training. And that program is still known as a regional leader in the work of aligning primary care and public health. I did move on to practice rural medicine for a few years. I did full scope family medicine with inpatient and obstetrics. And in that relatively short time, didn't get to dive deep into public health as much as I would have liked. And family circumstances led me back to the city a lot earlier in my career than I anticipated. And I've been working at the University of North Texas Health Science Center at Fort Worth since 2013. And that transition back to the city was a big learning curve because the healthcare system there is entirely different. And it took me many years of practicing, and I began to feel this sort of disconnect with public health and community health and some of those concepts. And that ultimately is what led me to seek out the PH-TIPP program and motivated to apply. So I'll begin with objective number 1, describe social determinants of health and their presentation in clinical care. Many of you already have a concept of social determinants of health, but there are many definitions. And this one is from Healthy People 2030. It says social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. As a family medicine doc, I simplify that and think that these are the factors that make it either easier or harder for people to prioritize the health and wellness of themselves and their family. In the picture icon, starting with that graduation cap in navy blue and moving clockwise, we have the components defined as education at the navy blue, healthcare access and quality in red, neighborhood and built environment in light blue, social and community context in yellow, and economic stability in green. Moving on from the definition, I'd like to share a few real cases to illustrate how social determinants of health may present themselves in the clinic setting. The first is a case of a no-show. My practice partner had a request for disengagement of an 88-year-old woman for having her third no-show in 6 months. But she was a longtime patient, and here's what we found when we asked about her situation. Her previous good friend had always helped her keep up with things, but she'd recently passed away. She now has a neighbor and church friend that bring her to appointments when they are able, but she has to pay them to help out with the gas costs, which comes out of her limited fixed income. So sometimes no one's available to take her to appointments, and sometimes she doesn't have the money to offer. She knows that Medicare offers transportation, but she can't really understand how to navigate that system to set it up. And often simply using her more modern phone that her children set her up with is difficult for her to call and reschedule appointments in a timely fashion. So she has social determinants of health that may have set her up for poor outcomes and were immediately was potentially going to get her fired from the clinical practice, but we didn't know any of this until we asked. The next case is one of medication non-adherence. So we have the cartoon, do you solemnly swear to listen to my advice, which I think unfortunately happens in a clinical setting sometimes. And here we have a 60-year-old man with uncontrolled hypertension, type 2 diabetes, chronic obstructive pulmonary disease, who is requesting an early refill on an albuterol rescue inhaler. And looking into the refill request, we could tell that he was not filling his medication on time. In fact, he was overdue for many other medication refills instead of the albuterol. He says at the time that he was taking insulin only when his sugar was really high, but not scheduled or as prescribed. So he's essentially trying to make it stretch. And same with his daily controller inhaler. He's using it only as needed to make it stretch, which is why he's needing his albuterol rescue inhaler several times per day and much more than expected. He also had declined most of his suggested health maintenance recommendations. So what's going on? Is he just that quote unquote non-compliant patient? No, here's what we found out. He simply could not afford all of his medications every month. In addition, he was also taking care of his sick parents at home, and his wife also had multiple chronic medical conditions and medications. The medical bills were a challenge, and he was prioritizing the care of his family over himself. At 64, he was waiting to get Medicare at 65 to get better prescription coverage and complete the recommended health maintenance items. So it's not that he wouldn't, it's that he couldn't make ends meet. And he wasn't comfortable telling us about this until we asked. And the last case I'll highlight is a case of behavioral non-adherence. So here we worked with a 14-year-old young man with obesity, dyslipidemia, and recent onset prediabetes who continued to gain weight. Why wasn't he losing weight? It was clearly documented multiple times in previous notes that he'd been counseled on diet and exercise. And the plan at last visit had been to begin walking home from school since he wasn't involved in after-school sports activities. So here's what we found out was really going on. He lived in a single-parent home, and mom worked mid-shift from 3 p.m. to 11 p.m., so wasn't at home when he got home from school. He was walking home from school as planned, but he was stopping by the local corner store to buy processed food and snacks to eat. His area was otherwise a food desert, and like many teenagers, he didn't always like the healthy food that mom was preparing for him and leaving in the refrigerator. So there was a park also close by, but he was not allowed to go there or be outside once he comes home because it's not a safe neighborhood, and he didn't have anyone to go with. They had recently moved again, which is why he didn't yet have friends and social support. Dad had actually been in prison for domestic violence, which unfortunately the patient witnessed, as well as other offenses, and had recently been released. And he and mom had been worried that he would try to find them. So he also hasn't been sleeping well at night. So all of these factors were impacting his engagement and behavioral changes. But again, we didn't know any of this until we asked. So in these real patient stories, you may have noted multiple social determinants of health that impacted the patient's care, including lack of education or health literacy, difficulty with accessing healthcare or underinsurance, difficulty with transportation, living in a food desert or unsafe neighborhood, social isolation, caregiver burden, domestic violence, and low income or multiple or odd hour jobs. So why do we care about social determinants of health in clinical care? Because the social determinants of health, like we saw in the patient story examples, may impact patient outcomes. And addressing social determinants of health will be key in accomplishing what the Institute for Healthcare Improvement frames as the triple aim, or CMS calls value-based care. And so this is improved patient experience, which is improved global satisfaction for patient care and improved quality of patient care, improved population outcomes, and doing so at a decreased per capita cost. From a clinical perspective, treating individual patients like the one in our stories, we need to know social determinants of health histories to create and modify patient-centered plans, ones that are actually doable for patients, ones that empower them to take the lead on their healthcare decisions within their social and cultural contexts. From clinical population perspective, we look at social determinants of health to know which are more prevalent. What resources could we provide centrally for our patients to remove barriers in engaging in healthcare and preventive services? Or where does it make more sense to work with a community partner to deliver care? And from a reimbursement standpoint, more reimbursements in a value-based system may come from the population health outcomes. So understanding drivers of population level outcomes and differences will be important for financial sustainable health systems moving forward. From a cost perspective, it's important to understand if social determinants are a root cause. So just in looking at the narrow lens of our patient stories, how many missed or wasted appointments did these patients have with a physician who was not ideally equipped to deal with their true need? A better and often more cost-effective strategy may be to identify social determinants of health up front and triage patients to team members that can best help them. We'll move on to objective 2 to describe the importance of social determinants of health in driving health outcomes and disparities. This slide highlights the impact of social determinants of health on health outcomes. The data is from county health rankings across the country, and researchers use linear regression to determine the contributions of different factors to healthcare outcomes. So if we look here, the socioeconomic factors of 47% and physical environment of 3% would combine to make the social determinants of health as described in the Healthy People 2030. And you can see that 50% of health outcomes are attributable to social determinants of health. This is a humbling statistic for a clinician that only 16% of outcomes are attributable to the clinical care we provide. And notably, that health behaviors contribute to 34% of outcomes, but realize that many health behaviors, just like in our patient stories, are impacted by social determinants of health. So healthier options may be the consistently more difficult option for someone to choose, or they may not be a choice at all for some. So how do social factors impact health? In the American Academy of Family Physician position paper entitled Advancing Health Equity by Addressing the Social Determinants of Health in Family Medicine, this diagram is referenced from the Bay Area Regional Health Inequities Initiative, a public health framework for reducing health inequities. And they talk about a stream of causation for how social factors impact health. The downstream factors in the far right, and then moving over to the left of the diagram, include things like morbidity and mortality, access to healthcare, behavioral risk factors, and living conditions. These are things in the traditional wheelhouse of medicine and public health. And to answer the questions of why there are so many people sick or why there are so many differences among groups, we look at the upstream factors more to the far left of the diagram, which include governance, culture, and societal values. High-level upstream factors like social, economic, and political mechanisms generate social class inequalities that impact large numbers of people in society. These structural determinants of health include things like the degree that government subsidizes healthcare or education, decisions about pollution, including minimum standards or where toxic substances are stored or released, and decisions about the built environment, which can either benefit or harm communities. And these all contribute to social class inequalities. Social factors either provide or constrain opportunities for people to access resources to promote better health. So individuals with low socioeconomic status are less likely to be able to acquire healthcare, nutritious foods, good educational opportunities, safe housing, and safe spaces for exercise, for example, like in our patient story. So the upstream and downstream factors shape the social determinants of health. In addition to this, differences in living conditions and opportunities to make healthy decisions result in different exposure and thus chronic stressors over time. So the position paper goes on to explain the concept of embodiment. And that is how humans biologically incorporate the material and social world in which we live. They describe that social factors are embodied as individuals are exposed to repeated and chronic stress, which the body normally physiologically responds to. Over time, chronic stress can increase the allostatic load or wear and tear on the body, and that accumulates in the body over time to cause health damaging effects. Historically, disadvantaged groups have been found to experience greater allostatic load and then more advantaged groups. And embodiment and allostatic load are thought to explain why social factors are linked to almost every measure of health status. And this does lead me to pull out one additional concept that I feel is not well represented in the Healthy People 2030 pictorial concept of social determinants of health. And that is the social construction of race and racism that has driven health outcomes and disparities. This slide has a direct quote from the CDC website. It states, "A growing body of research shows that centuries of racism in this country has had a profound and negative impact on communities of color. The impact is pervasive and deeply embedded in our society, affecting where one lives, learns, works, worships, and plays, and creating inequities in access to a range of social and economic benefits such as housing, education, wealth, and employment. These conditions, often referred to as social determinants of health, are key drivers of health inequities within communities of color and placing those within those populations at greater risk for poor health outcomes." And why is this so important to me as a Texas family medicine physician and public health professional and medical educator? Well, unfortunately, the Lone Star State is not a shining star when it comes to healthcare outcomes. We rank in the bottom 10 for all healthcare measures, with Black and Hispanic populations furthest from quality benchmarks outlined by the Agency for Healthcare Research and Quality. And at the same time, Texas leads the US in population growth rate. In fact, the Dallas-Fort Worth area is one of the fastest growing metropolitan areas, and that's where I live and work. And 87% of our growth is in non-white population. So if we're not explicitly addressing racism as a social determinant of health, if we are not becoming anti-racist in our approach to healthcare delivery, healthcare education, and population health management strategies, then I would pose we are not preparing the providers of the future to create healthier solutions for a more diverse Texas. And so I'll move on to recognizing strategies to address social determinants of health, including those to align primary care with public health. And I'll begin with our concept of combining primary care and public health. In our work within Family Medicine Department, we see ourselves as part of a larger national movement in family medicine. And so I wanted to highlight some key resources that we have used in planning our initiatives. The top two position papers are relatively brief reads with high yield concepts related to the integration of primary care and public health. And I've referenced them in some of the previous slides already. And we use the associated toolkits and projects that had been developed by the AAFP in our work. This is, again, the pictorial framework discussed in detail previously from the American Academy of Family Physicians position paper, Advancing Health Equity by Addressing the Social Determinants of Health in Family Medicine. And this same diagram and concept and framework was also highlighted in another position paper entitled Integration of Primary Care and Public Health. So a quote from that article reads, "For broad system change to succeed, family medicine must align with the public health sector to promote community-oriented primary care focused on upstream as well as downstream factors to create whole person concepts of care." And so the remainder of this presentation is how we implemented that call to action over the last couple of years within our family medicine clinic. And as an organizational structure for the remainder of the presentation, I'll follow the 5 levels described in the position paper: the physician level, practice level, community level, education level, and advocacy level. So start with how we use this call to action and model for transitioning our clinic. Starting at the physician level, and I do think that this could be more broadly to any provider, we must understand the role of public health has to play for you, your patients, and the community you serve, and demonstrate awareness of integration efforts between primary care and public health. So we see ourselves as again, part of a bigger team of family physicians. So first we began looking at what was going on in Texas. And we noticed that in the last few years, there were multiple publications through the Texas Academy of Family Physicians and Texas Medical Association describing how to integrate social determinants of health into clinical care. The same organizations and primary care physicians had been lobbying for change at the regional state level. And there were collaborative efforts between care providers and managed care organizations on how to better address social determinants of health for our patient population. And a recent article that was published during my PH-TIPP year is highlighted last year, talking about anti-racism efforts to the Texas Medical Association. And they highlighted specific data about lack of concordance in our physician workforce and the populations we serve clinically, and the resultant poor outcomes and economic impact. The highlighting of these topics regionally was very exciting to our team because we could see that there was already traction on the idea of addressing social determinants of health in clinical care within our state to align primary care and public health. And this also meant that we had partners in identifying policies and programs that we may be able to leverage at our own institution to do the same work. We also looked at what was going on at our own Health Science Center campus. Health Science Center-wide, part of the strategic plan was to develop a whole health model, and we wanted, as a family medicine team, to contribute to that work. So we evaluated our clinic system and family medicine and had iterative conversations amongst our team to align our personal goals with a whole health strategy. And one of the philosophical frameworks that was important to our team was osteopathic philosophy, which includes the holistic tenet that a person functions as the unit of mind, body, and spirit. And aligning with public health, we think more broadly that a person also functions integrally with a larger societal and community structure. Looking similarly at a popular whole health model from the VA, they expand on that mind, body, spirit concept. In the circle of health, the patient is the leader of their own health care, and the mind, body, spirit becomes 8 areas of self-care that impact wellness that surround the patient in this picture. And then the royal blue color represents the aspects of professional care and support that forms a larger circle. Encompassing all the other parts of the circle of health is the outer ring, the community. And the passport to whole health from the VA states that each of the 8 areas of self-care is influenced by or influences community in different ways. And so community connects us with the social determinants of health. In the whole health passport, it states that to truly be holistic in its scope, a whole health system focuses on bringing social determinants of health into the healthcare partnership and personal health plan process. So again, our family medicine team was excited to find a complementary framework and a whole health model to guide our work and our team goals. So next, we looked at the expertise we had built into our own team. My colleague, Dr. Crompton, had completed recently her American College of Lifestyle Medicine work and was preparing for her board certification. In developing our team strategy, we relied heavily on her knowledge of the ACLM's work with developing the VA Whole Health Program and her involvement with the Community Conversations Subcommittee of Health Equity Achieved through Lifestyle Medicine. But one area of expertise lacking on our family medicine team was a focus on population management, particularly developing programming to better systematically address wellness and preventive to improve our clinic population outcomes. And so I sought training through PH-TIPP to better fill that perceived gap in our team. At the practice level, the AAFP called for the following, which we felt we had the resources and autonomy to implement on our own in the family medicine clinic. And that was to identify critical social factors that impact patient health, leveraging the Everyone Project and data collection on social determinants of health in electronic health records. So I'll go over the major initiatives we developed at the practice level. Nearly all of my PH-TIPP policy analysis and program evaluation work applied to these initiatives at the practice and community level. So instead of highlighting each project separately, I'll attempt to demonstrate how the work informed the team initiatives. In this slide about alignment of service, don't focus on the details that are bullet pointed. I'll reference this diagram throughout the presentation of our work at the practice and leadership level. It is a visual representation of our family medicine team's whole health approach and how they align to create a financially sustainable whole health model for team-based care. The left half of the slide with the triangle is more traditional work of a clinical unit. So at the top of the triangle, we have the category of behavioral interventions. At the bottom right of the triangle, wellness and preventive care. And at the bottom left, chronic disease state management, as well as other episodic acute care. In the center of the triangle are things that support integration, such as chronic care management program, learner integration, and the work of what our clinic system calls the quality team, which does quality improvement efforts to capture population level metrics for certain insurers, but across the practice, not just with family medicine. The right half of the slide depicts steps in alignment with community and public health models. Moving from the top to the bottom on the right, we have population health, or population is defined by our practice and then subdivided by insurer to transition to values-based care and alternative payment models as opposed to fee-for-service. And of note, our clinic system is predominantly operating in fee-for-service now, but would like to begin to transition more to values-based payment model. Then moving down, redefining our population, more like public health based on social determinants and geographic location, leading down to strategic community partnerships to develop community-oriented primary care. So diving more into the wellness and prevention, we see wellness and prevention as the cornerstone of care. So during wellness visits, personalized health plans and strategies to stay well are outlined. Evidence-based screening and preventive measures are reviewed. What matters the most to the patient in their life context is documented so that it can be a focus of the patient's overall care. And baseline and annual assessments are done along with levels of motivation to address each of the following: lifestyle behaviors, social determinants of health, mental health, functional abilities, and spirituality. Ideally, each patient should have a one visit per year focus on wellness and prevention. And at this visit, the plan of care for the entire year should be negotiated with the patient, an agenda set and shared with the patient in writing. And chronic visits could be scheduled throughout the year. Baseline and annual assessments outlined above could drive in-house consultations, and a personalized team could be built out for the patient. Patients who are eligible for chronic care management services or program, especially without a copay, could be verbally consented during this appointment for enrollment. Preceding the PH-TIPP year, our team led by Dr. Crompton had begun a quality improvement project to increase the proportion of our patients who are eligible for and had completed a Medicare annual wellness visit. So this process involved updating schedules, training for the clinical staff, providers, and the revenue cycle team, and key changes to the electronic health record templates to capture or automate required components of the visit. And the QI project was largely successful because we aligned it with a clinical system level strategy to obtain an Institute for Healthcare Improvement age-friendly designation, and we were able to do so. But piggybacking on that larger system strategy, the family medicine department strategized to specifically increase the proportion of dual eligible patients with both Medicare and Medicaid who had annual wellness visits. Historically, this insured population faces more social determinants of health, barriers to wellness, and has more complex medical conditions and increased need for coordination of care. Just prior to acceptance in PH-TIPP, I had stepped away from managing my own patient panel to do annual wellness visits for mostly dual eligible patient population and grow the chronic care management program in parallel. A short-term outcome with these strategies was to demonstrate the ability to cover a physician's time and overhead with this model with only the fee-for-service revenue, and this outcome was achieved. With chronic disease management, the general goal was to empower patients in self-care to resolve, control, or reverse conditions. And this included medication management, targeted behavioral modification, osteopathic manipulative medicine, and importantly, modification of plans to suit the patient's social cultural context. Like with wellness and prevention, each patient has an individualized plan of care, an individualized team based on their preferences and level of control of their chronic conditions. Uncontrolled conditions would drive in-house consultation to other team members to build their team. Integrated behavioral health supported patient self-efficacy over time in managing chronic conditions, and ideally alignment of public health and social services to appropriately address upstream needs with community resources or community-oriented primary care service lines. Medicare does allow for wellness and chronic disease visits to be billed on the same day in a fee-for-service billing structure. So like other clinics that are fully transitioned to prospective payment models and value-based system, I saw approximately 6 patients per half day in very thorough visits that outlined plans of care for not only their Medicare annual wellness visit, but also complex chronic conditions, as well as completion of enrollment paperwork for the chronic care management program. And so primarily through this process of wellness and chronic disease management together, we were able to begin building a layered team-based care approach that identified medical complexity, the social determinants of health that were driving outcomes, and the types of personalized teams and plans that each patient needed. The general goal with behavioral interventions was to optimize personal, physical, and mental and spiritual health. The lifestyle medicine focused on the ACLM 6 pillars of lifestyle, which included nutrition, sleep, connectedness, activity, stress management, and avoidance of risky substances. Patients motivated specifically for lifestyle changes could engage in lifestyle consultations, shared medical appointments, or disease state-specific counseling. Personalized strategies were based on the patient's needs, their motivation level, their abilities, and their social determinants. And as mentioned before, these lifestyle changes may be applied to wellness and prevention or disease state management. Mental health focused behavioral integration was still in the early planning phases, so it's not really included or discussed here. And I won't go into a lot of detail presenting the intensive therapeutic lifestyle change because it wasn't a main focus of the PH-TIPP work. However, the shared medical appointments grew in parallel to the chronic care management program from my referrals of predominantly dual eligible medically complex patients who often had social determinants that impacted their lifestyle. And so it was really neat to see success stories within that program because unfortunately sometimes in medicine that quote unquote non-adherent patient and those non-adherences to a plan are due to social determinants or not having partnered on a plan to begin with. That can be misinterpreted as lack of motivation or lack of caring on the patient's side to make changes. So it was really nice to have in-house examples of how that's not the case, and tailoring plans and paying attention to that holistic care can really help. It was also really neat to watch the community and social support that developed within the groups. Many have formed friendships and continue to work with us in community activities. And so our hope for the ITLC shared medical appointments would be to grow this program over time as well as part of the value-based care transition, as similar programs have been shown to decrease prescription and emergency department utilization rates, as well as overall health costs and improve patient outcomes. From the circle in the center of the triangle on the left of the screen, I'll highlight chronic care management services, which is the subject of a portion of my policy analysis and program evaluation of PH-TIPP. CCM allows a clinical team, all clinical team members to contribute to billing in a layered team-based care model, which helps transition from fee-for-service to values-based care teams. To avoid potential additional charge to patients, it's ideal for dual eligible patients or certain supplemental insurances like TRICARE or some Medicare Advantage plans will cover the copays. In addition to the enrollments that I've described, my work with this program included development of workflows, standing orders, EHR updates, and dashboard development for appropriate reactive and proactive management of chronic care management patients. Like with the annual wellness visit initiative, CCM had begun prior to the PH-TIPP year and the development of the whole health team goal. But our clinic had begun CCM over 5 years ago to financially support specifically integration of the ambulatory care clinical pharmacy team. And I've been a champion of that work for the last 5 years or more. And many even fondly call me the AmCare cheerleader. But CCM is a service outlined by CMS for Medicare beneficiaries with 2 or more chronic conditions, and is ideally meant to help with coordinating care for those chronic conditions and can be used more broadly. There may be copays involved if services are billed. However, many supplemental insurances like Medicaid, TRICARE, and Medicare Advantage plans cover the fees. Whereas our family medicine team had recommended comprehensive care plans as part of the annual wellness visits and chronic disease state management, the CCM enrollment requires a comprehensive plan of care, and updates to the CMS final rule now require that plan to include the patient's need for any support services socially and their environmental histories in that plan of care. So for our dual eligible and often more medically complex patients, the CCM enrollment meant that not only would their social determinants of health histories be documented in the chart, but also our clinical team could now be reimbursed for the time spent coordinating care and services for these patients. More recent literature supports use of the CCM model to build out teams and transition to value-based care and better population health management, with examples of coordination of care for preventive services and integrating members such as community health workers and health coaches, which are known to help improve outcomes in the public health arena. So leveraging CCM in the fee-for-service world to transition to a high percentage of revenue from value-based care and alternative payment models would be a medium or long-term goal for the HSC Health Clinic over the next 3 years or more. As far as the CCM growth through the strategy of annual wellness visits for dual eligible patients, I've pulled a snapshot from the CCM dashboard. This is a run chart of minutes by month by provider. And so on the x-axis on the left, we start with January of 2020, and it goes all the way to the right, which is April of 2022. The y-axis starts at the bottom with 0 minutes and goes up to over 2,000 minutes. And the red line represents minutes billed under my name. So that's the line, if you can't see the color, that's the line that progressively increases kind of midway through the graph. I've highlighted 2 points in time with coupled vertical lines. The black solid lines just right of center are the period which family medicine had assistance with scheduling from the quality team. And with that initiative, one can see the market increase in the red line that was for coordination of care related to needs of enrolled patients. And though that rate of growth plateaued without scheduling assistance, billing for the care coordination of enrolled patients, you can see that it sustained pretty well over time. Now looking at the green vertical couple lines to the right, this is during December 2021 and January 2022. And this represents the holiday time when I had scheduled time off during the academic year. And then in January, when I was ill with COVID and was not able to see patients in person for part of the month. Yet we don't see a significant dip in the CCM productivity. And this was an excellent finding as a short-term outcome in an academic clinic setting, because it makes us more robust to changes in faculty FTE structure as we try to transition from fee-for-service to more value-based payments. Here, I've simply pulled out a snapshot from the EHR to demonstrate some of the automation we've built into the CCM enrollment plan of care, which includes standardization around guideline-based management for bread and butter conditions, preventive services, and prompts to assess for social determinants of health using the PREPARE assessment and behavioral health factors. And again, this is a snapshot from another aspect of the CCM dashboard, representing color coding built in for proactive outreach. So here, the reddish color indicates that this is a patient that we need to negotiate and document an outreach interval with that patient. We're not currently doing proactive outreach with them. And the orange means that we are past due for outreach on that patient. Outreach can be scheduled based on the frequency of weeks as it's currently programmed. So for instance, we may reach out to a patient with a recent hospitalization weekly until we know that chronic conditions are stabilized and controlled, or a patient with multiple chronic conditions may prefer to be reached out to once a month in between scheduled office visits. Or if a social worker works on navigation of a social need, they may want to reach out to the patient once a week until they know that the issue has been resolved. Next, I'll transition into more detail regarding our social determinants of health screening strategy in family medicine, which has been referenced already as being included in the wellness visits and the CCM enrollment plans of care. A key CMS change to E&M coding in 2021 allowed us to incorporate social determinants of health in medical decision-making, meaning that many 99213 visits could be converted to 99214 visits. This was another focus of policy analysis during my PH-TIPP year. And to put that into perspective, if you're an average family medicine physician, then you bill 42% of your office visits as 99213. And so say 25% of those can now become 99214s, and that's a significant amount of additional annual revenue at $35 a difference per visit. And again, I point this out just because many clinic systems outcomes must include short-term financial sustainability within a fee-for-service structure while they're trying to turn the corner and create a system for values-based care and population-focused outcomes. You can see these Z codes are just diagnosis codes for the social determinants of health. So examples are like problems related to education and literacy, problems related to employment and unemployment, problems related to housing, related to the social environment, related to social support. And these can now be used to increase the complexity of the visit. When beginning to address social determinants of health in the clinic setting, it's important to decide who will collect the information. In our system, the learners led the project, and I'll talk about that a little bit more later. That wouldn't be the case in most systems. I would expect it to be more different team members like nurses, medical assistants, support staff. Ideal choices might be care coordinators, patient navigators, or health coaches who could also help navigate the coordination needs. And then there's some systems that deliver the surveys electronically. The next step is to pick a tool to use, and we used the Prepare tool because it was integrated into our EHR and automatically populated the diagnosis on the day that it was administered. And when we deliver the survey or when we collected the history has changed over time with more outreach during the height of the pandemic, and then mostly in wellness visits, and then risk-based screening for uncontrolled chronic conditions, non-adherence, et cetera. And we have begun a new strategy for proactive outreach again. Here I show another clip from a test patient in EHR just to show the level of automation we were able to build during the PH-TIPP year. Once the social determinant of health history is collected, the Z code is not only documented in the assessment for that day, but it's pulled over to the ongoing problem list along with the statement that's necessary for billing purposes. And vetted resources, local resources of that patient will be populated in the patient plan if it's generated either electronically or printed for the patient. So this reduces initial level of work that was previously done by social worker or team member, or maybe a team member that we didn't have the resources to employ. So what have we found in our clinic? Thus far, we have over 1,000 patients with the social determinants of history is documented on chart. This is over 10% of our approximate 7,000 patients. Here we have some data where we were able to find state level comparison. So I'll orient you to the graph. The left or purple of each couplet is the state level data, and the right or blue is the clinic level data. And we can see that in the domain of education on the far left, our clinic has a much higher percentage of patients with less than high school education or GED. Left of center, we have food insecurity. And here we fare a little bit better than at the state level. However, we've noticed subpopulations within our patients, such as women of childbearing age, food insecurity, which is difficulty accessing food in the last year, is much more prevalent. Housing, again, we fare better than the state. And I think this is because we have local initiatives to provide community-oriented services for patients experiencing homelessness. So that's less prevalent in our population that arrives at clinic. And then on the far right, we see that unemployment in our patient population is about 3 times the level of the state data. We looked at some predictive statistics, including stress, because Texas apparently is the 10th most stressed state. And in our population, we found that higher scores on the social determinants of health survey were predictive of higher levels of stress. Thinking back to our no-show case example, we also found that there was a statistically significant difference in the prepare score of a no-show cohort and a show cohort. And the positive predictive value here was 87.5%, meaning that for a patient with a high score on their social determinant of health screener, there was a 9 out of 10 chance that they would miss more than one office visit in an 18-month period. And I highlight these predictive statistics because I feel that they are really practical examples of how we can use data to think more upstream in a clinical setting and design appropriate programming to better serve our patients as we work on those upstream factors simultaneously. So now I'll look at things that we did at the community level. Again, in our clinic model, this starts to move us over to the right side of that scheme. Here I'm showing a geomap of our patient population, specifically looking at population quality metric gaps in our Medicaid 1115 waiver program. And to the far right, we see that the zip code where our patients live that are having the most trouble accessing preventive services is in the 76116 zip code. So strategically, we engaged the community with, we started with the Walk with a Doc program, which is a national organization backed by the Texas Medical Association to engage community members in physical activity. So physicians and medical students organize walks in the community and invite their patients, their patient families, and community members to join them. And they typically begin with a 5 to 10 minute talk about a healthcare topic, and then spend the rest of the time walking, visiting, answering medical questions as they come up in conversation. The idea for Walk with the Doc placement was strategic. We wanted to start this in an area where the needs were greatest. So we did choose our zip code with the most quality metric gaps for our clinic. But it was also important that the Walk with a Doc occur at a place where people were already going, and ideally paired with other needs like Tarrant Area Food Bank. So through a connection with Tarrant Area Food Bank, we developed a relationship with LVT Rights Community Center to start Walk with a Doc, which just had its 1-year anniversary last month. Through this relationship, we've also been discussing ways to expand clinical services at that location. And we've piloted things such as a flu vaccine clinic and screening for blood pressure and glucose. Additional community level activity included more communication and collaboration with the more common local managed Medicaid organizations. One example, and this was part of my PH-TIPP policy analysis, to leverage a change in state policy that allows managed Medicaid organizations to count social expenditures for patients in their healthcare expenses instead of their administrative expenses bucket. So here we worked with AmeriGroup, Tarrant Area Food Bank, and a local grower. AmeriGroup was willing to fund placing a food bank with fresh produce to supply for the patients in our intensive lifestyle therapeutic change programs. Unfortunately, we weren't able to move forward with this project, but hope that we'll be able to soon. But we have partnered with AmeriGroup on other local initiatives. Other community engagement included increased collaboration with other schools on campus who have not traditionally been involved in our clinical service line. So this was the School of Biomedical Science and School of Public Health, who house our health coaching, community health worker, and community health worker instructor training. We've done pitches for innovation with our innovation lab, HSC Next, as well as we've been collaborating on projects for community-oriented primary care service lines with the Institute for Health Disparities, and hope that those lines will come into fruition over the next few years. At the education level, we'll start with the undergraduate medical education. For the core medical school curriculum that's delivered to all medical students, we did publish a whole health module in family medicine clerkship. This module addressed components similar to this presentation, including addressing health equity and family medicine introduction, U.S. Preventive Service Task Force recommendations for preventive care, health disparities in LGBT population and why they occur, patient-centered care example videos, implicit bias training, social and structural determinants of health, ethics, policy, and advocacy, and then lastly, big interview, mock residency interview questions related to this content area and associated ACGME core competency domains. At our specific clinic, we also focus on value add task-based roles for learners, and this involves and a picture example of this is on the left, but this involves outlining all the tasks involved in patient care for a clinic, matching tasks to competencies of each profession of learner, determining the level of supervision needed for each task, and then identifying win-wins for value add. So for us, those are ideally tasks that address core competencies for the learners, ones that the learners enjoy doing, but that minimize disruption to workflow and patient-centeredness during the office visits themselves, those that the patients believe are helpful, and tasks that can be done under reactive supervision. Often clinical support tools that are specific to students need to be developed so that they can complete these tasks under reactive supervision. And sometimes it's necessary to develop pre-sequenced curriculum so that the students are more prepared prior to coming to clinic. But a specific example of this value add learner integration has been the SDOH initiative. And here I'm really proud to say that dual degree students, DO and PH, began this project with us and have maintained it over time from the very beginning, including planning workflows, selecting the tool, instructions on how to use the tool, piloting the program with a single provider, and then developing student workflows and support materials, helping to design the clinical curriculum for core students, as well as more recently preclinical learner outreach. And Dr. Crompton and I have been able to get a small grant with the Texas Academy of Family Physician Foundation to develop a toolkit to help other community preceptors integrate learners in the same way to address social determinants of health. As far as GME, Dr. Crompton developed a lifestyle medicine track for our residency program here. We are one of 82 other programs now offering this additional training to residents. And again, within this program, residents gain experience in two changes in primary care and public health. And that is one, panel management, and the second, not listed here, is inclusion of a patient on patient advisory committees so that our care becomes more community oriented. Last, I'll just briefly highlight some of our advocacy level efforts, which are mainly sharing this type of information with professional societies, our local Academy of Medical Educators, and then ongoing participation in the Society for Teachers of Family Medicine, Academic Family Medicine, Anti-Racism Learning Collaborative, as well as Health Equity Achieved through Lifestyle Medicine. And we do hope to continue and expand our work, including advocacy at local and regional levels to encourage addressing social determinants of health in a clinical environment, as well as other learner integrated approaches to align primary care and public health. And so I know that was a lot really fast, but thank you for listening, and I'm available for questions at this time.
Thank you so much, Didi. That was a huge body of work you're doing, and thank you so much for doing all that. I had there's a couple questions in the Q&A, but I was wondering if, well, there's two things. One, if you have a question, there's a Q&A box on the bottom of your screen you can click on, and you can submit questions that Didi will answer if given time and appropriate to the topic. One of the questions I had before we go into the other ones is when you looked at the score that was higher for certain patients, one of the areas I would be interested in is this idea of making automatic. uh, how you address those different factors in the health record or in the way in which people are showing up. So for instance, like no-show, you get people that have a higher score with no-show. I wonder if you could talk a little bit more about that, and if not, that's fine too. I'm interested in this idea of having indicators where you're able to sort of automatically scale up into a higher response that improves of being able to access healthcare.
So is the question about which components within the screening tool were more predictive of a no-show?
Not just the predictive part, but like knowing that the predictivity, how predictive it was, the intervention therein. And it might not be there yet, right? In saying, hey, this is predictive, which it seems like you have a fairly good grasp on, but then this is what we're gonna do, whether that's a more frequent text message, follow-up reminders, interaction with other healthcare staff.
Yeah, I think some of that programming has to be built out, but things would be, like you said, more frequent reminders. I think patients that are having more social needs, and they might be more sensitive to bringing up those topics, continuity of care and a more trusted relationship with their care team is important. So for example, the medical assistant I work with most consistently with the chronic care management program, there's a lot of patients that maybe like me okay, but they really trust her. And so maybe with the chronic care management program, she can help take care of them in between visits, and they're not going to, they won't get charged maybe the same, or it's not as difficult for them to be able to access her than it is to come in and see me for an office visit. So other times might be, knowing that a certain patient just needs transportation services, or like getting to the root cause of why they aren't coming and just addressing that social need. Like, is it like our patient example that just needs help setting up the Medicare transportation services? Or do we need to see a patient out at LVT Rise where they can get their food or have a place for their kid to play while we talk to them about their health care? And so I think those things need to be more developed as programs, but those are some examples of how we might address that over time.
It's super neat. And I really, really, really appreciate that view and all the work that you're doing. And if you could talk for a little bit about how the policies, that the evidence that you're bringing to the table, and then the policies that are affected. You talked sort of towards the end about the policy component, but I wonder if you could expand a little bit on that, how it works out. We have some time. If you feel comfortable to talk about, I was thinking about state level policies or county level policies that affect how people are accessing or affected by social determinants of health. I'm not saying the exact right way I'd like to, but things like jobs and other aspects in the community that are affected by it.
So the question is more about what policies I think we should be engaging with locally and regionally, or is the question about what policies did I look at with policy analysis?
I think what policies you looked at with the policy analysis, okay. And then with this idea of that connectedness to other activities, other policies within that framework. Like in the end, you had the different medical societies involved in that, but then that connection to state level policy, county level policy.
Yeah, I think so. It's almost easier for me to think about it as if the long-term goal is to do values-based care and have more prospective payment models, and what that team looks like, because that team is going to include health coaches and community health workers, and is going to probably be more community oriented. And clinics that are already run like directly by Medicare Advantage, their teams are already set up that way, right? But their payment model is so different. So you have to backtrack it to a clinic like ours that is mostly fee for service. And it's not that we wouldn't want to build out a team like that, but how do you get reimbursed for that? How do you, grants, maybe yes, but like, how is that going to be sustainable over time? And so we kind of looked at that and chose policies that for community organizations like ours or community clinics like ours that were more fee for service, what were the policies that could incentivize us to start building those teams that could ultimately be those value-based care teams? And so those were ones that were, how do we fund the people and the time it takes to not only collect the social determinant of health information, but then once we get positive screeners, who's going to follow up on that? And so if our clinic makes, let's say, $250,000 extra per year, that's not maybe a lot of money in the big scheme of things, but that is enough money to pay for an extra team member or two to help specifically with that work. So it kind of helps build that team over time. So we looked at that policy. CCM was another policy that we really leveraged, and I think could be leveraged even more for the same reasons, because it essentially becomes a free service for the dual eligible patient. Then it allows us to build a care team that can help navigate those social determinants of health. So we really looked at that policy and how is it being used elsewhere, and what kinds of team members could we start rolling in under that fee for service structure with the long-term goal of creating that value-based care over time. The one that we weren't able to fully leverage that was that local, that regional policy was with the managed Medicaid. And I think we could leverage that a lot more with asking the financing to come from the managed care organization. So examples of things I've seen with is the managed care organization actually setting up the food bank or giving patients cell phones or helping supply a community health worker. Like if our clinic has a really high percentage of patients that are insured by that managed Medicaid, maybe they will pay for a case manager or a community health worker for that patient population. So those are some examples. Again, I hope we get that food bank over time, but they've also funded some work with community-oriented primary care with our rural osteopathic medical education program, where we've been able to do some remote clinics in some underserved areas of Texas with that AMERA group helping pay for those clinical service lines through the education department. So those are some examples. But I think locally, some of the things that I would maybe push for would even be, and it might have to go beyond locally, but for example, the CCM program, it would be nice if those codes could be applied to other beneficiaries besides Medicare beneficiaries. We have a large population of patients that we serve that have Medicaid but don't qualify for Medicare, and so they may have similar needs as the dual eligible patient, but there's not that ability in that fee for service structure to build a team around better service for that patient. So I think that's probably all in there, because I'm not sure if there's so many directions you can go. I think the most important thing for a clinic is to start collecting the information and know your own population that you serve, and start looking at that data in aggregate to know what policies do I need to advocate for my patients, and where can I get that resource for my patients? Who do I need to collaborate with in the community? Who out of public health do I need to be working with so that my patients are better served upstream?
Mm-hmm. Yeah, and one of the questions in the question and answer box is sort of relates to that, and I think that that's really critical in being able to delineate where your friction points are for social determinants of health in your community. And one of the questions was about you have a much higher unemployment rate versus the state, but your housing rate is better, and for food security is better, and so. There was a person wanting to know a little bit more about why that is, but then I think it also speaks to that idea of having data to drive decisions.
Mm-hmm. And I think too, like specifically with that, I think I mentioned it during the presentation a little, but there's a couple things that Tarrant County has done well, and our food bank has done pretty well, I think. And they have, as part of their strategic planning, tried to get into the healthcare space. So they have already tried to do collaboratives with community organizations and healthcare organizations so that the food insecurity rate would be lower. And so I think because those programs are there, then we're doing better than the state average. The housing, again, one of our TCOM graduates that went to JPS is now the medical director at a clinic with the county hospital that's a community-oriented. They have a community-oriented care line that serves patients experiencing homelessness. So a lot of patients experiencing homelessness know that that is the place to go, and it's already set up where there's more outreach specifically for that patient population. So again, I think that means that I will see less patients experiencing homelessness and that arrive at my door because there is a system for better serving their need. So I think we're doing better than the state in that regard, if that makes sense. Some of the unemployment is, I think, interesting. I think some of that may be data collection error because we did find in our data that we'll report to TAFP in the toolkit, there are certain areas where students don't have enough health systems knowledge, and I think they're collecting some of the information inaccurately. So for instance, they have trouble differentiating someone who might have unemployment but have medical disability and are on Medicare and are getting at least some financial support versus other not being employed by choice versus someone who's looking for work and needing work but can't find it. I don't think that's well differentiated in our data. And I think if it was, it would probably look different than the state level data.
And I think that's an important point too. And it comes back to some of the knowing which population your clinic serves, and knowing that that's a dynamic situation over time. Say you have a different person come in that has a specialist or some specialty in certain area, diabetes, social determinants of health, and our person's experience homelessness, it probably would shift your demographics of use. But then also it speaks to this idea of having accurate data collection and ensuring that your analysis as accounts for that. One of the questions was related to the whether there's a reference or some sort of list of social history questions that address social determinants of health beyond sort of like alcohol, tobacco. I think the person's looking for like, are you experiencing homelessness? Have you had a meal in the last couple of days, or have you experienced food insecurity? You might not have a ready, like off the cuff place to put it, but if you have one or two references or places people can start looking, or how you found it would be helpful.
Yeah, the prepare, am I able to put that in chat?
Yeah.
I think Prepare has a website and their information is free and has been translated to multiple languages.
Mm-hmm.
AHRQ also has a more extensive questionnaire that some systems use. I believe that's what they use at where I went to residency at the FQHC. So I think you can search AHRQ. And then the AAFP also has a free PDF, which is just a brief screener. So those are three that we've looked at before and considered in our clinic. But again, the Prepare, again, can be ideal because it is integrated into some of the EHRs as a free add-in. Mm-hmm. And CMS has expanded the codes that can be used for billing purposes in parallel to that screener, the Prepare tool. So if you're using that tool and you're needing to leverage that fee-for-service component, then the Prepare might be a good one to use because the Z codes that it pulls into your chart are ones that can be used for medical complexity of decision-making.
Okay. Yeah. Those are really a lot more resources than we're able to get them out fast. When you partner with community-based organizations, you talked a little bit about this, but maybe expand on it, or as how do they get reimbursed? Is that contractual? Do your 1115 waivers allow for direct contracting with CBOs? You mentioned it. You probably mentioned it, but I didn't catch the exact part. No,
I didn't. I mean, so mostly the organizations that we've partnered with strategically because they already have some funding to be supplying something that we feel like our patients need is kind of the organizations that we have worked with so far. Mm-hmm. Now, in some of our other collaboratives with grant funding, the clinical service line component and the billing may be built in after. So it may be grant funding up front to to start, say, a clinical service line out of a community center, and then leveraging the chronic care management services, for instance, to be able to start billing and create financial sustainability over time. But usually the community organizations already have their own funding structure. So like me as a clinician, other than if we create a service line and I can help contribute to financial sustainability for billing for those clinical services, we haven't been bringing the funding to the table other than collaborating on grants.
Makes sense. Makes sense. The next question is about education as a social determinant of health, and one of the questioner is asking about whether it's the academic educational level or the patient's understanding of their situation, of the condition and diagnosis.
On our screener, it is the formal educational level, which I can tell you does not equate with health literacy. You know, I use my dad as an example, and I won't tell stories right now, but formally educated and health literacy just makes some decisions that I'm like, come on, Dad. But I wish some tools do, there's separate tools for health literacy. That is one of the partnerships we would like to create on campus. We have an institute called Safer Care Texas, and one of the people there, Dr. Teresa Wagner, she's an expert in health literacy. And so we would like to do more specifically health literacy screening, because I think that would be an intervention that we could do in clinic, would be to make sure that all of our materials and our communications are tailored towards our patients and health, and then having programming to improve health literacy. Because I think that's the underlying determinant, is not your level of formal education, but it's your health literacy. I think that sort of answers your question in a really long-winded way.
No, it does. Especially in a time where there's a lot more information accessible on the internet, or misinformation therein as well. I think it's important to meet the person where they're at in their understanding of that condition.
And I feel like as a primary care doctor, I think this is why a primary care doctor, especially a family medicine physician, is in a good point to help align primary care and public health. My mom tells me, you know, Didi, we think that your greatest asset as a family doctor is that you're a doctor to English translator. And so I think that's kind of true. I mean, I think primary care teams really should engage in that work of making sure that plans and messages are tailored to fit the social cultural context for the patient, so that they can be more, have more self-efficacy in being the leader of their healthcare.
Yeah, I think that's important to have an ability to translate those two languages. One of the questions was about this Walk with a Doc program, and it sort of ties back into quantification. Is it more about rapport or access to care? Are you really answering a lot of questions during that time, or you're more about creating a trusting relationship, or maybe a combination therein?
It's a combination. It's been really interesting because I feel like in my social world, you know, there's some people that maybe only reach out to me when they need answers to a medical question. And then the patients, on the other hand, that have come to walk with a doc often are trying to be very respectful to not treat us as physicians while we're there, and they just hang out and walk with us. And we've had to encourage them to say, like, hey, you know, we love hanging out with you and getting to know you, but also if you have any questions, like, we're here. And so it's become a combination of both over time, but it actually took some time to get there. And then we do hope to have more clinical services there, so that patients aren't having to come into the clinic, because they do offer other resources, and childcare and student volunteers come out a lot. So there's a lot we can accomplish at one time for the patient in the community if we're able to build that out over time.
Yeah, it probably takes a great degree of coordination and effort on everyone's behalf to make that all happen, and applaud that. Can you talk a little bit about engagement with employers to help with community referrals? And I think any clinic has some engagement with the community, but it sounds like you have more employer-related engagements.
Not sure what you mean by employer-related engagements.
So, and I just don't know that the Fort Worth area well enough, but is there a series of major employers that you work with to come back and say, hey, we're starting to offer some services that your employees might be interested in?
We have pitched that particularly through the ACLM shared medical appointments. There's a turnkey program called CHIP, and I don't have stock in that or anything, but that program has been implemented with different healthcare providers as part of the delivery. So not just physicians, but maybe health coaches and PAs or nurses, and is often targeted at employer-based wellness or employee-based wellness. So major in the area might be like Lockheed Martin or Amazon or the school districts, because each school district, I think, contracts their own insurance coverage for in the state of Texas. So we could contract with a school district. So there are plans for that, because I think there's a lot of workplace wellness and like building of blue zones